A sudden change in memory can feel like the beginning of an irreversible disease. A familiar name disappears. An appointment is missed. A person who has driven the same route for years takes a wrong turn and cannot explain why. Families often assume the answer is simple. Age has finally caught up. Sometimes that is true. But sometimes the explanation is sitting in a weekly pill organizer, a bedside drawer, or an over-the-counter bottle that nobody thought to mention at the medical visit. Older adults process many medicines differently from younger adults. The liver and kidneys may clear drugs more slowly. Body composition changes, the brain can become more sensitive to sedating effects, and several prescriptions may interact even when each one seemed reasonable by itself. A medicine that once caused only mild drowsiness can later produce confusion, poor concentration, balance problems, or a frightening sense of mental fog. Those symptoms do not automatically mean dementia, but they deserve attention. This matters because medication-related cognitive problems can be missed. A specialist may see the heart medicines. Another clinician may manage sleep. A bladder prescription may come from a different office. Meanwhile, allergy tablets, nighttime pain products, and supplements may never appear on the official list. Nobody intends harm, yet the total burden can quietly grow. Today we are examining 9 medication categories that deserve a closer look when an older person develops new forgetfulness, slowed thinking, unusual sleepiness, or confusion. This is not a scientific ranking from harmless to dangerous, and it is not a reason to stop treatment. Some of these medicines are essential. Some risks are well established, while others are uncertain or depend heavily on dose, duration, and the person taking them. The purpose is to help you ask better questions. Pay particular attention to medicines that block acetylcholine, a chemical involved in attention, learning, memory, bladder function, digestion, and many other processes. Also watch for drugs that broadly suppress brain activity, especially when several are combined. The strongest warning in this video is simple. Never make abrupt medication changes based on a list online. Withdrawal, rebound symptoms, seizures, uncontrolled pain, psychiatric relapse, bleeding, or cardiovascular events can be more dangerous than the concern that prompted the change. Instead, gather every product you use, including non-prescription sleep aids and PM formulas, and review them with a physician or pharmacist. New confusion can also come from infection, dehydration, low sodium, low blood sugar, thyroid disease, vitamin deficiency, stroke, depression, sleep apnea, or another urgent condition. Medication review is one part of a proper evaluation, not a substitute for it. If confusion begins suddenly, especially with weakness, facial drooping, trouble speaking, severe headache, fever, chest pain, or inability to stay awake, seek urgent medical care rather than waiting for a routine appointment. I am Dr. Richard Kim. Before we dive into the science, please take a brief moment to like this video, subscribe to the channel, and share it with someone you care about. Your continued support allows this channel to grow faster than I ever imagined, and it empowers me to keep producing these in-depth, scientifically grounded health guides for as many people as possible. Thank you so much for being part of this community. Let us begin at number 9. Again, the number does not measure exact danger. The real risk depends on your health, dose, treatment length, and what else you take. What matters is recognizing patterns that are easy to overlook. Number 9 is the first-generation antihistamine group, especially diphenhydramine and doxylamine. These ingredients appear in allergy tablets, sleep aids, and many products labeled nighttime or PM. Because they are sold without a prescription, people often assume they are suitable for nightly use. That assumption can be risky in later life. These medicines block histamine, which contributes to their sedating effect, but they also have strong anticholinergic properties. In practical terms, they interfere with acetylcholine signaling. In an older adult, that can mean dry mouth, constipation, blurred vision, urinary retention, daytime drowsiness, poor balance, slowed reaction time, and confusion. The mental effect may be obvious after one dose, or it may look like a gradual loss of sharpness when the product is used repeatedly. The key point is not that everyone who takes diphenhydramine will develop dementia. Observational research has found an association between greater exposure to strong anticholinergic medicines and a higher rate of dementia, but such studies cannot prove that one tablet directly caused the disease. What is already clear is that these products can impair attention and memory in the short term, trigger delirium in vulnerable people, and increase fall risk. Check the active ingredients rather than relying on the brand name. A pain reliever marketed for nighttime use may simply combine the usual pain medicine with diphenhydramine. A separate sleep aid may contain the same ingredient, creating an accidental duplicate. If allergies are the problem, ask whether a less sedating option is appropriate. If sleep is the problem, look for the cause before reaching for an antihistamine every night. Pain, sleep apnea, restless legs, depression, caffeine, alcohol, and poor sleep timing may require very different solutions. Do not throw away a prescribed medicine without guidance. Bring every package to a pharmacist or clinician and ask one direct question. Does this product add meaningful anticholinergic or sedative burden for me? Strong anticholinergic drugs, including first-generation antihistamines, are specifically highlighted in geriatric prescribing guidance because of confusion, cognitive, and other adverse effects. Number 8 is long-term proton pump inhibitor use. Common examples include omeprazole, esomeprazole, pantoprazole, and lansoprazole. These medicines reduce stomach acid and can be extremely useful for reflux, ulcers, gastrointestinal bleeding prevention, and several other conditions. For some patients, continuing them is clearly safer than stopping them. The concern begins when a PPI was started for a short-term reason and then continued automatically for years without reviewing whether the original indication still exists. Lower stomach acid can affect the absorption of certain nutrients, including vitamin B12 and magnesium, although not every long-term user becomes deficient. A deficiency in either can contribute to fatigue, weakness, nerve symptoms, confusion, or poor concentration. Those problems may be mistaken for normal aging if nobody checks. You may have heard claims that PP is directly cause Alzheimer's disease. The evidence is not settled. Some observational studies have reported an association, while other well-designed studies have found no meaningful increase in dementia risk. People who need PPs may also differ from non-users in age, illness, medication load, and vascular risk, making cause and effect difficult to separate. A responsible message is therefore not, "This drug destroys memory." It is long-term treatment should have a reason, and new cognitive symptoms deserve a complete review. Ask why you are taking the medicine, what dose is necessary, and whether monitoring for B12, magnesium, anemia, kidney function, or other concerns makes sense in your situation. Some people can step down, use treatment intermittently, or manage triggers such as late meals, alcohol, tobacco, excess weight, or specific foods. Others should remain on a PPI because the benefit is substantial. Do not taper or substitute it casually. Rebound acid production can make symptoms surge after sudden discontinuation, and untreated ulcer or bleeding risk can be serious. The goal is not fear. The goal is appropriate treatment at the lowest effective dose for the correct duration, guided by a clinician who knows why it was prescribed. Research on PPs and dementia remains inconsistent, although nutrient and other long-term treatment considerations may justify periodic review. Number 7 is the group of bladder antimuscarinic medicines used for urgency, frequency, and overactive bladder. Oxybutynin is the best-known example, but the category also includes medicines such as tolterodine, sulfasenacin, fesoterodine, and others. These drugs can reduce embarrassing leakage and make it possible for someone to travel, sleep, shop, or socialize with more confidence. That benefit should not be dismissed. The problem is that these medicines work by blocking muscarinic acetylcholine receptors. The bladder may calm down, but some agents can also affect the brain, especially in older adults. Oxybutynin has long raised particular concern because it can cross into the central nervous system and may cause confusion, sleepiness, and memory difficulty. The degree of risk differs among drugs, doses, formulations, and individuals, so the whole category should not be treated as identical. If memory problems started after a bladder medicine was added or increased, write down the timing. Also notice dry mouth, constipation, blurred vision, difficulty emptying the bladder, or unusual drowsiness. because several anticholinergic effects may appear together. A clear timeline gives the prescriber something useful to evaluate. There may be alternatives, but they are not automatically right for everyone. Bladder training, scheduled bathroom visits, pelvic floor therapy, constipation treatment, review of diuretics, and reducing evening bladder irritants may help. Beta-3 agonist medicines, such as mirabegron or vibegron, work through a different pathway and may reduce anticholinergic exposure, yet they have their own cautions, including blood pressure concerns or interactions in some patients. Even switching within the bladder drug category requires individualized judgment. The safest step is a shared decision. Ask how much the medicine improves your quality of life, whether a lower risk option exists, and how your total anticholinergic burden looks when every medication is counted. You should not have to choose blindly between bladder control and mental clarity. A careful plan can often protect both. Oxybutynin and several related bladder medicines appear among drugs with notable anticholinergic properties in geriatric prescribing criteria. Number 6 is the most misunderstood category on this list. Statins, including atorvastatin, simvastatin, rosuvastatin, and pravastatin. These medicines lower cholesterol and reduce the risk of heart attack and stroke in many people. Because strokes are a major cause of disability and cognitive decline, protecting the blood vessels can also help protect the brain. Rare reports of forgetfulness or confusion have appeared with statin use. Regulators have described these events as generally non-serious and often reversible after the medication is changed or stopped under medical supervision. However, large reviews and long-term studies have not shown that statins commonly cause dementia. Some research has found no effect on cognition, and some observational evidence suggests statin users may have a lower dementia risk, probably because vascular events are prevented. That distinction matters. A frightening story may convince someone to stop a statin overnight, yet the immediate result could be a higher risk of heart attack or stroke. The correct response to suspected cognitive side effects is not silent discontinuation. It is a structured review. Start by asking when the symptom began. Did it follow the start of the statin, a dose increase, or the addition of another medicine? Are sleep loss, depression, thyroid problems, alcohol infection, low B12, or another condition more likely explanations? Is the person taking a dose appropriate for their cardiovascular risk? Would a different statin, lower dose, or alternate schedule preserve protection while improving tolerability? Those are clinical questions, not decisions to make alone. It is also important to separate temporary brain fog from progressive dementia. A medication-related complaint that improves after a supervised change is different from a neurodegenerative disease, and neither should be assumed without evaluation. Statins are included here because viewers often hear alarming claims about them, not because they belong among the strongest anticholinergic offenders. If your statin is preventing another stroke or treating very high cardiovascular risk, the benefit may be substantial. Keep that benefit in view while investigating symptoms carefully. Protecting memory sometimes means reducing a problematic drug. It also means preventing the vascular damage that can permanently injure the brain. FDA labeling recognizes rare, generally reversible cognitive complaints, while systematic reviews have not found consistent evidence that statins cause dementia. Number 5 is the benzodiazepine family and related sleeping medicines. Lorazepam, alprazolam, diazepam, clonazepam, and temazepam are familiar examples. So-called Z drugs, including zolpidem, are not chemically identical, but they can create similar problems with sedation, coordination, memory, and falls. These medicines enhance inhibitory signaling in the brain. In the right setting, that can stop seizures, treat severe anxiety, manage alcohol withdrawal, or provide short-term relief during a crisis. The problem appears when a temporary rescue becomes a nightly routine without regular reassessment. Older adults are often more sensitive, and some long-acting medicines can accumulate because the body clears them slowly. The effects may include daytime sleepiness, slowed thinking, poor attention, gaps in recent memory, unsteady walking, and confusion. A person may appear to be declining cognitively when part of the picture is persistent sedation. Combining a benzodiazepine with alcohol, opioids, sleep medicines, or other sedatives can further impair breathing and alertness. Falls, fractures, car crashes, and delirium are immediate concerns, even before anyone discusses long-term dementia risk. Research on whether benzodiazepines directly cause dementia remains difficult to interpret. Anxiety and insomnia can appear years before dementia is diagnosed, so the medicine may sometimes be a marker of early disease rather than its cause. Still, the short-term cognitive risks and dependence potential are established enough to justify caution. The most important warning is about stopping. After regular use, abrupt withdrawal can trigger severe anxiety, insomnia, agitation, tremor, confusion, and seizures. A safe reduction is usually gradual and individualized. Some people need weeks, others need months or longer. The pace may need to slow when symptoms appear. Ask whether the original reason for treatment is still present and whether non-drug care can support a taper. Cognitive behavioral therapy for insomnia, treatment of sleep apnea, consistent wake times, anxiety therapy, and carefully selected alternatives may help depending on the diagnosis. Do not let shame interfere with this conversation. Physical dependence is an expected biological response, not a personal failure. The goal is stable function, safe sleep, and clear thinking, achieved without an abrupt or dangerous exit. Current guidance emphasizes older adults' increased vulnerability and recommends slow, individualized tapering rather than sudden cessation. Number 4 is amitriptyline and other strongly anticholinergic tricyclic antidepressants. Amitriptyline may be prescribed for depression, nerve pain, migraine prevention, or sleep. Because one low-cost tablet can address several complaints, it may remain on a medication list for years after the original reason is changed. In older adults, the difficulty is not limited to memory. Amitriptyline can cause sedation, dry mouth, constipation, blurred vision, urinary retention, low blood pressure when standing, and an increased risk of falls. Its strong anticholinergic activity can also impair attention and short-term memory or contribute to delirium, particularly during illness, dehydration, hospitalization, or a dose change. Long exposure to strongly anticholinergic medicines has been associated with a higher rate of dementia in observational research. That does not prove that amitriptyline inevitably causes permanent disease, but it strengthens the case for avoiding unnecessary cumulative exposure. The question is not simply whether the dose looks small. A modest dose taken every night can still contribute to the total burden when it is combined with bladder drugs, antihistamines, or other sedating products. If amitriptyline is helping, identify exactly what it is helping. Is nerve pain meaningfully lower? Are migraines less frequent? Is sleep better, or is the person merely sedated? The answer guides the next discussion. Alternatives vary by condition and carry their own risks. Duloxetine, gabapentin, topical treatments, physical therapy, migraine-specific prevention, or a different antidepressant may be considered, but none is universally safer for every patient. Do not replace one drug with another based on a video. Some alternatives can cause dizziness, low sodium, sedation, withdrawal, or interactions. A clinician should compare the real benefit you receive with the risks created by age, falls, heart rhythm, constipation, glaucoma, urinary problems, and the rest of your medication list. If a change is appropriate, amitriptyline is usually reduced gradually rather than abandoned without a plan. Amitriptyline remains specifically identified as a strongly anticholinergic medication in geriatric prescribing guidance. Number 3 is paroxetine, an SSRI antidepressant, also known by the brand name Paxil. SSRIs are often described as a modern class, but paroxetine is unusual within that group because it has stronger anticholinergic effects than many of its relatives. It can also be sedating and may contribute to dizziness or low blood pressure in some older adults. Paroxetine may be effective for depression, panic disorder, anxiety, and other conditions. The concern is not that it never belongs in treatment. The concern is that an older person may remain on it for years, without anyone revisiting whether another option could provide the same psychiatric benefit with less cognitive burden. Warning signs can include new forgetfulness, slowed concentration, unusual sleepiness, worsening balance, constipation or dry mouth, especially after starting treatment or increasing the dose. But depression itself can impair memory and attention, sometimes so strongly that it resembles dementia. That makes careless conclusions dangerous. If cognition worsens, both the illness and the medication need to be considered. Geriatric prescribing guidance lists paroxetine among medicines that are often best avoided in older adults when safer, effective alternatives are available. Other SSRIs, such as sertraline or escitalopram, generally have less anticholinergic activity, but they are not risk-free. They may affect sodium levels, bleeding risk, heart rhythm, sleep, or interactions, depending on the person. Never switch antidepressants abruptly. Stopping paroxetine suddenly can cause dizziness, nausea, anxiety, sleep disturbance, electric shock sensations, and a rapid return of depression or panic. Transitioning to another medicine may require a slow taper, cross taper, or another individualized strategy. The practical question for the prescriber is straightforward. Is paroxetine still the best match for this person's age, symptoms, medical conditions, and complete medication list? Mental health treatment protects quality of life and can support cognition when depression is well controlled. The aim is not to remove effective care. It is to choose that care with the lowest reasonable cognitive and physical burden. Paroxetine is listed in the Beers criteria because it is highly anticholinergic, sedating, and capable of contributing to orthostatic hypotension. Number 2 is antipsychotic medication, including quetiapine, risperidone, olanzapine, and similar drugs. These medicines have legitimate uses in schizophrenia, bipolar disorder, severe psychosis, and selected cases of dangerous agitation. One medicine in this broader class has also received specific approval for agitation associated with Alzheimer's disease. That does not make routine use harmless. In older adults, antipsychotics can cause sedation, slowed movement, low blood pressure, metabolic changes, abnormal movements, swallowing difficulty, falls, and cognitive dulling. For elderly people with dementia-related psychosis, the class carries a boxed warning about increased mortality. Cerebrovascular events are another serious concern. Benefits and risks therefore need to be documented clearly, especially when the drug is being used off-label for sleep or manageable restlessness. A person who becomes quieter after an antipsychotic is not necessarily better. Sedation can reduce visible behavior without treating pain, constipation, infection, fear, loneliness, hearing loss, medication withdrawal, or an overstimulating environment. Families should ask what symptom is being targeted, how improvement will be measured, and what would trigger a dose reduction or discontinuation attempt. Non-drug approaches are not empty advice. A predictable routine, daylight exposure, better sleep timing, hearing and vision support, familiar caregivers, regular movement, adequate food and fluids, and treatment of pain or infection can reduce distress. These steps require time, but they may address the cause rather than suppress the outward behavior. Sometimes medication is still necessary because the person is experiencing severe distress or poses an immediate danger. In that situation, clinicians generally aim for the lowest effective dose, the shortest practical duration, and frequent reassessment. No family should stop an antipsychotic suddenly without professional guidance, particularly when it is treating a major psychiatric illness. The central question is not, is this drug bad? It is, what precise problem is it treating? What benefit are we seeing? And is that benefit worth the current risk? When those questions have no clear answer, the medication deserves prompt review. FDA labeling continues to warn of increased mortality in elderly patients treated for dementia-related psychosis. Number 1 is not a single bottle. It is the combined anticholinergic and sedative burden created when several medicines overlap. This is where a reasonable prescription from one office, an over-the-counter sleep aid from the pharmacy, and an old pain medicine from another clinician can become a problem that nobody sees in isolation. Imagine an older adult taking oxybutynin for bladder urgency, amitriptyline for nerve pain, diphenhydramine at night, and a benzodiazepine when sleep becomes difficult. Each medicine has a purpose. Together, however, they may produce dry mouth, constipation, urinary retention, dizziness, poor balance, daytime sedation, confusion, and memory trouble. Adding an opioid, alcohol, or another sleep product can increase impairment further. This cumulative effect is called medication burden. Researchers and clinicians use several scoring systems to estimate anticholinergic exposure, but no score replaces judgment. The same numerical burden may affect two people differently because of kidney function, frailty, dementia, Parkinson's disease, glaucoma, prostate problems, falls, or other vulnerabilities. What matters is that the total is reviewed, not merely each drug one at a time. The hopeful part is that some medication-related cognitive impairment can improve after the responsible drugs are reduced or changed. Improvement may appear within days, weeks, or months, depending on the medicine and the person. But it is unsafe to promise complete reversal. A drug may be only one contributor, and an underlying neurological condition can exist at the same time. A medication review should therefore accompany, not replace, a proper cognitive assessment. Prepare for that review carefully. Make one list containing every prescription, inhaler, patch, cream, eye drop, supplement, cannabis product, alcohol use pattern, and non-prescription tablet. Record the dose, the time taken, the reason, who prescribed it, and whether it truly helps. Include products used only occasionally because as-needed medicines can still matter. Then ask the physician or pharmacist to identify duplicates, interactions, anticholinergic medicines, sedatives, and drugs that may no longer have a clear indication. Changes should happen one at a time when possible, with a monitoring plan. That makes it easier to see whether memory, alertness, sleep, pain, mood, or bladder symptoms improve or worsen. The greatest danger is not simply taking many medicines. It is taking many medicines without one person seeing the complete picture. A coordinated review can preserve needed treatment while removing avoidable burden. Research and geriatric guidance recognize cumulative anticholinergic exposure as a clinically important concern, particularly for cognition and function in older adults. Before you leave, choose one practical action. Do not empty your pill organizer. Do not skip tonight's dose. Instead, schedule a medication review and bring the complete list. If possible, bring the actual bottles. Ask whether every product is still necessary, whether any two are doing the same job, whether your kidney or liver function changes the dose, and whether the combination could be affecting memory, balance, or alertness. Also write down what you have noticed. My memory is worse is important, but details are more useful. Note when the change began, whether it fluctuates, which activities have become harder, and whether symptoms appeared after a new prescription, dose increase, illness, hospitalization, or sleep disruption. Ask a family member what they have observed. A clear timeline can help distinguish sedation, delirium, depression, medication effects, and progressive cognitive disease. Remember that sudden confusion is not normal aging. If a person becomes abruptly disoriented, cannot stay awake, develops weakness on one side, has trouble speaking, experiences a severe headache, falls repeatedly, or has difficulty breathing, seek urgent medical help. Do not wait for a medication appointment. The larger message is encouraging. Memory changes should be investigated, not dismissed. Aging can alter recall, but a noticeable decline deserves a search for treatable contributors, including medication effects, sleep problems, mood disorders, infections, metabolic abnormalities, hearing loss, and vascular disease. Asking questions is not disrespectful to your doctor. It is part of safe care. Look at the bottles in your home tonight and write down every active ingredient. Then arrange one careful review rather than making 10 frightened changes. Protecting the aging brain is rarely about finding one villain. It is about reducing avoidable burden while preserving the treatments that keep the rest of the body stable. I am Dr. Richard Kim. Stay informed, involve your healthcare team, and treat new confusion as a signal worth investigating. In the next video, we will examine physical signs that may deserve medical attention and explain which ones are meaningful, which ones are commonly misunderstood, and when it is time to seek professional care.